Dr. Manav Jyoti Burman, Kardeva Netralaya, Guwahati, and rest of us will be here soon. So basically, this is a IC for uh, meant to be, something to showcase dialogue, showcase, issues that we often have between our surgeries, in between surgeries, and we have to tide over these issues. So this is basically a surgery, complication. Uh, uh, I see. Dr. Rupak Biswas is here. Please come on stage, please. So, this we have thereby named the IC a dialogue between mentor and mentees on iatrogenic complications in vitreoretinal surgery. So we have a August panel here. We have Dr. Aniruddha Maiti, Dr. Manav Jyoti Burman, Dr. Shubhendu Boral, Dr. Rupak Biswas, and we have two exuberant VR surgeons, Dr. Ashmita Shaha and Dr. Priyam Biswas. So I welcome them all also, and I welcome you all also. So we'll start off with the first, couple of cases, a few cases that Dr. Ashmita is going to show us. So please, Dr. Ashmita, please come on stage.
Good morning. Every surgeon has complications and we should know how to manage it. AIOS presentation slides. Yeah, this is the first case. It's coming very fast. It's not showing here, but I have uploaded it.
But you have the pen drive, na?
Yes. Should I bring my pen?
Ito tomorta naki. Can you connect her laptop? So that will be better. Because this is another presentation, not her. Speed to change होगा ना.
Hello. This is the case one where I had a complication while there was a vitreoretinal adhesion, and at that area we had a break and then we lasered it. This is the second case where old RD, where ILM peeling is being tried. Repeated attempts resulted in a break near the disc. Then this is a case of an ERM where PVD induction is being tried at the posterior pole. Mechanical induction resulted in a retinal break near the disc, which resulted in a tear, and we had to laser it just next to the disc. This is the other case where we did the PVD induction, and there is a strong vitreoretinal adhesion around the lattice area, and we tried to do the posterior vitreous. This is another case. So we lasered that area around the disc. This is another case we did with PVD induction, and then the lattice, we had a break around the lattice while doing posterior vitreous detachment. Thank you.
Thank you, Ashmita. Nice presentation. So we will be discussing later, and may I request Dr. Anirudh to, take up from here on. So he will basically be talking about, managing iatrogenic breaks and retinal touch. So Dr. Anirudh, please.
Thank you, Debdulal. Well, I will be showing you iatrogenic break and how to Okay. Let's see few cases where this iatrogenic complication has happened, and then we will have videos how to prevent this. So this was an vitreous hemorrhage with TRD. Nasal TRDs at times are very bad. It's very difficult to take up with the cutter. The only option is a bimanual option, which should be tried. This membrane was this retinal membrane initially was not taken up by the cutter, and then we use this faucet. So nowadays the using of the faucet should be minimal, because we have got very good instrumentation, and we can prevent this iatrogenic break. In order to remove this membrane from the nasal side, this break was created. So this can be prevented by a bimanual. Now, this is how it should be done, where we can prevent this iatrogenic complication. You can see a very tabletop TRD case over here, even more difficult than the previous one. Meticulous dissection, dissecting out the membrane, or rather the plane of dissection is very important. Once we get the plane, we can do a conformal cutter delamination. We have to go along with the shape of the globe so that we don't touch the retina. Sometimes the planes are very difficult to get, and we can use the side of the section or the section to make it plain, and then the job becomes. This is how all the diabetic cases should be approached instead of using the faucet. Another technique where we can prevent the iatrogenic break. Nowadays, due to the good instrumentation, we don't use much, but very severe, large fibrovascular membrane, this is the only option that you have to approach by here and do a bimanual dissection where you can manage the membrane without causing any nitrogen and managing all the things. The technique, typical technique is a small snip. You have to go underneath the membrane and begin the membrane and the retina. Once it is detached from the and this is another way we can prevent blood. Sometimes, as I mentioned in the first case, the nasal tears are pretty bad, so we are not getting the plane. Here we are using the proportion of the blood, making it plain, and then proceeding with the segmentation. Now you can see that I can insulate my cutter and the plane in between membrane and the retina. Once we have segmented, it is easy to delaminate, and once this delamination is over, we have to cauterize the needle. Three techniques where we can prevent an iatrogenic break in capital case. Macular cases, or to prevent a retinal touch, generally it is not that common, but it can happen if you are a little bit close to the retina. And in this case, almost the case was over. In the last bit, touched the retina, and it was a little bit big. This kind of break actually can be left because of the posterior pole. It doesn't make any difference. But if you feel that it is a full thickness one, do a laser for you. Absolutely not at all treated. But this kind of break can be left behind. But we need to be very careful about and very sure about the plane of the eye. And this is usual case. Rather than touched by the soft tape, because we are pushing the DVD and the assistant was new and the push is hard and the soft tape actually went inside and hit the retina. So the only good part was it was directed towards not in the center of the port. Whenever you put the dye directed towards the nasal side or very controlled way, drop by drop fashion. Regmetrogene and RD are sometimes cases like this. Bullet RD very close to the retina, especially with a 20 case when you are doing the peripheral dissection. You need to be very careful. This is how yes, this break has happened because the vacuum was more and there was always better to reduce the vacuum, especially in the 20K cutter, to prevent. The other way to prevent it is to stabilize depress it with a depressor. Depressor in any case we are using, but depression actually makes that part of the retina stable. The chances of iatrogenic break is less. That will prevent any iatrogenic. please. You need to take care of the tractional membranes in diabetic cases first before stabilizing the retina, as we mentioned in the earlier case, because we have to address both the parts, the regular business artery as well as the tractional membrane. So you have to resect the membranes first, then do a PVD, mark the break. You can see once the membranes were released, the other part of the retina was quite fuller. So there was a big break superior. Same way you put the tapes in, the cilium scaling on the leaves. Now things become easier. Obviously, this is a combined artery, so it will do a very good job. So these are the following few tips which we can follow and prevent any iatrogenic complications.
Thank you, Dr. Aniruddha. That was wonderful. We are open to questions, but one first question I would like to ask is, what would be your guidance for creating a plane or searching for the plane?
I think all diabetic cases are different. Some cases we need to actually approach from the center, from the disc, and some where the PVD has not happened, you have to actually put the triamcinolone and do the vitrectomy and search for the ages where we can actually start the vitrectomy. And in order to do so, sometimes we can get it while inducing removing the vitreous. In order to get it, we can use this following tools also, like you can use the proportional reflux, or we can use the bimanual technique if it is very difficult or very large fibrovascular membrane. But I think put triamcinolone, do the vitrectomy, automatically you can actually get the age and start the dissection from there.
One other thing that you've shown is in a macular hole, we often have, we touch the retina, or while removing the ILM with the forceps, we can grasp the retina. So this is something that is not to be scared of, as you have shown. But maybe for some of the beginners, it will be prudent to tell them that whether you use gas or oil in these cases. So what would be your choice? Do they need to put in oil?
I don't think any oil is necessary for this case. The gas is good enough.
Right.
Sometimes there is always a tendency, I've seen people are mingling around the edge of the macular hole to make sure that in order to tuck the ILM, but that's actually not required. But in order to do so, sometimes the hemorrhage happens. I can give one example, like there was an hemorrhage, one of my colleagues had an hemorrhage and the hole closed. Later on, that patient had a CNVM from that side. So tucking or mingling around the edge of the macular hole should be avoided, because nowadays we give flaps and that is good enough to close the hole instead of tucking the ILM into the hole. That's not required actually. Yeah. Yeah. Actually, laser in the posterior pole, I showed two cases. One was the touch with the soft tape. That was a big one, and it was oozing. And it was nasally also. Nothing happens. That patient got 6/6 vision also. But the other one, we could have opted for not doing a laser. It was just a touch, and you are putting a tamponant, and it's in the posterior pole. So you might not do it at all.
So iatrogenic macular hole during retinal hole during macular hole surgery is relatively common. So it should not happen.
Because
it happens because most of the time our focus is to the macular hole. So one of my cases that my fellow that injected triamcinolone during vitrectomy, and in the cannula there was some triamcinolone particulars there, and my assistant gave me the cannula, same cannula, and I injected the dye. And that triamcinolone particles, they hit the retina and they created a large hole. Fortunately, it was just from the macular, central macula. So these are certain situations that.
Was this staining under air?
No, I injected under fluid only.
Fluid only.
So this is one situation like your
Because this is another complication what Dr. Borman was telling. If you stain it under air, there is a chance of jet injury.
Yeah.
So it is not required actually. The staining under fluid is equally
so
good.
these are certain. And as Asmita has
There are
shown that
chances of
there is a lattice
complication.
that break was formed. Na? So in such situations, maybe what I do is I just go to the from posterior to anterior, from the to the anterior edge of the lattice, and then from anterior to posterior, from the posterior edge of the lattice. I think this is a technique that we can avoid some hole formation or break formation in the lattice. What do you feel?
In fact, you have to trim it because you cannot take entire vitreous from the lattice. You have to shave it.
You cannot remove anterior vitreous.
It is not possible. You have to shave it and with a minimal vacuum.
Yes,
So
better
that
not
it
to
doesn't-
pull like, as we do in a
Because
PVD.
the scapular retina will come and there
If
will
you
be
pull it
iatrogenic.
from posterior to anterior, definitely there is high risk of break formation.
Break
So
formation, yes.
yeah, so I go to the
side.
periphery and then I come from anterior to posterior towards the lattice because the anterior vitreous is relatively easy to remove from the lattice.
Thank you, Dr. Aniruddha. So we'll move on to the next presentation. Dr. Priyam Biswas, please. So she will present some interesting cases. And one thing is that, what we are trying to portray is that, vitreoretinal surgery has to be done, and there is no, nothing too much about doing a vitreoretinal surgery, and one should not be too scared about, doing vitreoretinal surgery. So let's watch our beautiful videos. Priyam, please.
Good morning, respected seniors, and thank you, sir, for giving me this opportunity. So I am going to show two cases where we have landed up with iatrogenic breaks during management of proliferative vitreoretinopathy. So that is not actually the end of the world, having these breaks. So it was a 55-year-old male with diminution of vision for the past 8 months in the right eye, visual acuity of hand movement. So the patient had retinal detachment along with staff-fold PVR changes, as you can see with the video. The initial part of the surgery was done. Transdermal injection, the residual part was being removed. So now with the help of a forceps, we try and lift up the edge of the membrane, and gently we try and release it with the cutter. We are trying to cut off the membrane. So you see that the video has now been slowed down on purpose because I'm trying to show that we went a little overboard during pulling this mobile retina on the abdominal membrane. We went a little overconfident, and there have created an iatrogenic out there, not one, quite a many. So next again we go on process little by little. We are trying to segmentalize the membranes as the and we are trying to cut it off with the cutter in the inferior part of the retina, and also again trying to remove the membrane from the big break that I have created. So here of course I have to be a little cautious. I cannot afford to have many mistakes. So moving on, we are trying to do base sheathing vitrectomy, and I'm also trying to look for residual membrane. So that's the last part of the membrane that was released. So now marking on the break is an endoscopy, and here you can see there are inferior breaks as well. So next we go and do a linear external, initially with the cutter itself, and little by little the retina is kind of settling down. So more or less the membranes are released, the retina is flattening out, and next we do it with the stitching tool, and next is the relieving procedure, a good 360-degree laser barrage is done, and of course the break has to be barrage as well, and then a silicone oil implant is given with these procedures, and the patient had a vision of 5 hours completed. So this part will be told by my mentor. So I'll be going to the second case of a 58-year-old female with diminution of vision in the left eye for 5 months with a visual acuity of hand movement. And again, as you can see, that the case of retinal detachment with proliferative So should I play? Oh. They হচ্ছে না কেন? হ্যাঁ হ্যাঁ হয়েছে হয়েছে। So as you can see that the pediatric are right at the history of the process. We are trying to release the membrane, and it's a very risky place where we are very close to the disc, and there he's accidentally grabbed the vessel and now started moving. So with the help of the corset and the light we are trying to negotiate the membrane, but didn't get it much. So since it's a bleeder, it has to be cauterized immediately. It will be limited the visibility otherwise. So next we go on to bleeder exchange in the hope that the macula opens up. And here we have landed up with two surprises. One was the hole that I was expecting, but the full thickness macula hole was totally unexpected. So next we went in for staining the intervening membrane with a serum blue dye, and since it was a detached retina, for some amount of fluid, CSVL was injected, and under CSVL, alanine was here is being tried. So we are trying to remove as much of internal limiting membrane as possible. That has to be graded off as well. And next we completely phased off by lasering off the draining retinopathy. Now the hole, the macular hole, that has to be closed, and what better way than by directly draining fluids from the hole itself, and it closes on paper. And then a silicone tamponade was given, and the patient was chosen on 6/6/2024. So what my take-home message is, what my mentor always tells me, whenever you have a break in this initial part of your surgery, do not panic, stay calm, treat it as any other break. Complete all the membrane, try and remove as much as membranes as possible. When there is bleeding, try and stop the bleeding. Do not again go in for harsh cautery, because I've done that and I've induced another break with cautery as well. So lesser the breaks, better is the prognosis, lesser are the chances of recurrent RD and again ERMs and re-PVRs. But then what my mentor tells me and what I followed is the most important thing. Never lose hope when you have a break. All breaks can be mended. And when I had my first break, sir is sitting right here. So sir told me that if you have not had a break, you have not operated at all. So I would like to wind up here. Thank you for kind listening.
Thank you, Priyam. That was wonderful. And the last line was the most important line. Never lose hope. So jaan hai to jahan hai. So we move on, and Dr. Rupak will discuss these. So her mentor. Welcome, Dr. Rupak.
Thank you, Dr. Debdulal, for putting this excellent format of IC and making it more interactive. And thanks, Dr. Priyam, also for excellent presentation. Now, the most important is that PVR management, one instrument which can handle all kind of PVR patients. So only one instrument if you have, you can manage, I think, all level of management. So this is just a routine information about the PVR. Average incidence is around 5 to 10% of the cases, but it varies from where you are practicing and what is your referral base. On that basis, it usually varies. This is the usual cases what we do get to see in different areas. And here in our audience, I think Dr. Natwar is here. why don't you come in front? He is practicing in UK, so would like to have your few inputs that how do you see cases there. So at the end we will take your few comments also. So now the most difficulties are starting from the placement of trocar, injury to the lens, retinal break during. These are all kind of complications can happen during PVR management. What you can expect or you cannot expect. So of which the most important part, I think these are the intrinsic contraction of the retina, the inability to deattach the retina. These are the most important area where you can focus for this. For anterior PVR, it is most difficult that where to place the trocar and cannula. So most of the cases, if you use 6 millimeter cannula, then you can overcome this. But make sure that your cannula is into the vitreous cavity before you start. This is causing lot of in case of PVR, it is already a complicated case. So if you make it more complicated by make a intraoperative choroidal detachment or intraoperative subretinal cannula, which is making your surgical time not only increasing, but again it is making the situation more difficult for you. So be very careful from the very beginning, because you know what you are dealing with. So I'll just show you a few of those. So when you have this membrane, now you think about it can be of the anterior PVR or it can be a posterior PVR, it can be a combination of both. There can be a subretinal gliosis also. So any kind of situation you can have, and then you need to handle one by one. So if you have the posterior PVR, so it is better to have some amount of the dissection in the anterior part, then go down. So immediately if you try to go down, dig and then try to fill up the membrane, it is not going to happen, because unless and until you remove it. So most importantly, the dissection, any kind of dissection, forget about the vitreoretinal dissection. Dissection has some amount of the basic principle of any surgery. So what happens, unless and first thing is that if you don't see, don't operate. So unless until if you go and blindly go down, if the it is well covered, disc is not seen, and you go down there and try to gasp the membrane, no, it is not going to happen, and invariably you will catch up of other tissue other than the membrane. So try to dissect of the anterior part as much as possible and go there. If needed, yes, some amount of the PFCL, that part, PFCL will not help you in the dissection, but PFCL will some amount of the stabilization of the tissue wherever you are, and then you can, for the better visualization also, you can take the help. But again, with PFCL on, the dissection under PFCL is sometimes is easy, sometimes is difficult also, because if you have a fixed fold, then it will not go into that part. So it will come on the other part, causing that once you start pulling it off, the other part becomes where you are operating, that part becomes more bullous. So anyway, I mean, these are the small things which you need to take the decision intraoperatively. So let's see if this is the a small video which is showing a bimanual dissection of the membrane. So once we were discussing about that near the break where the lattices degenerations were there and they were not able to shave it. So that is for those who are early PVR, yes, you can get shave and then get away. But if you have a significant amount of the PVR near the break, so unless until you clear that area, it's very difficult to settle the retina, or the chance of recurrence is very high if you don't remove those membrane from the near the break. So in that, do not hesitate to go ahead for the bimanual dissection in that area. That bimanual dissection is as like similar to the PDA dissection, PDA membrane dissection. So yes, having this PFCL is an important tool. So you can, especially when you have a little bit of early PVR, that is the strategy should be a little difficult from the advanced PVR. Early PVR is sometimes it is even difficult to manage, because if you have the immature membrane, it's very difficult to visualize, very difficult to grasp that membrane. So these are the two basic difficulties what you are facing there. Sometimes if you are not able to dissect the membrane around the break, then you can put the PFCL and cover with the PFCL, go up to the break, and then start dissecting under PFCL with cutter or any other instrument. Now the problem is that if you use cutter under PFCL, then the PFCL will start decreasing in bubble. So give a little more amount of the PFCL and go in 2-3 steps. You may need to use little more amount of the PFCL, but doesn't matter if you can end up of the clearing that area much better. So I'll just show it. Yeah, this is just an example to show how I have covered it. This subretinal gliotic band management is very tricky in some situations. The most important is that location where the subretinal gliotic band is there and how you are going to approach to that area, depending upon whether you are left-handed surgeon, you are right-handed surgeon, where you are sitting. So multiple other issues are there, and putting all of them together, you need to take the call. See here, is just to show you, it's a very thin retina, thin retina, old retinal detachment, and significant amount of the, yes. This is a pull by, not by in one go. If you try to pull it in one go, there is always a chance of enlargement, yes. So this is by the, every time you take it out and then again go to the base, again pull it, so that the amount of the pull what you are pulling, so from that your forceps, the tenting should not be very high. If your tenting is high, it can actually act as a scissor to cut the retina, so that your the small hole what you have made is actually, you will end up having an incisional break. So these are the things, small things, if you need to take care of it. Yeah, in early PVR changes also, sometimes you can manage by doing a meticulous PVD. You can the immature membrane can take out along with this. So in this situation, a very slow and meticulous PVD induction also can help you a lot. And there, if you feel that there is some amount of the immature membrane is still remaining there, can gently nudge with your even with the cutter. Stop cutter with the other side of the cutter, you can just simply rub it and you can see where the membranes are getting. So if you have an immature membrane, suppose is here, and if you are nudging it here, you will see the whole retina, instead of coming, the whole fold moves. If the whole fold moves, then there is some amount of the membrane will be there. So by these small things, you can just identify how it is. Intrinsic contraction of the retina, you need to take the call according to as per the situations, and if needed, liberal retinotomy can save you for that kind of purposes, or a radial retinotomy also can help you in multiple radial retinotomy to settle the retina properly. So this is what sometimes you can land up of having a small central amount of the island of retina, but again you can manage it. Fixing the curled retinal edges, yes, it is possible. You can gently nudge it, because in this kind of situation, the more you can cover the amount of the exposed choroid is better. But again, most importantly, the curled retina, if you make it unfold, then the margin PVR development at later stage becomes less, so that the chance of recurrence becomes less. Thank you. These are few points which can continue the discussion.
Yeah, thank you, Dr. Rupak. Wonderful videos and tips. Dr. Aniruddha has a question.
I think we were discussing that sometimes vitreous is on the lattice margin where we can trim, but if the vitreous is in the break, then we have to take care, and if necessary, we can actually trim the edges. There is no harm rather than having vitreous on the edges of the hole. Rather you trim it and then diatomize, and this is one thing. And PVD in TRD is very tricky. PVD, it is not the PVD what we normally induce. We have to see where the focal attachments are there. You have to be very careful. And in your case, I think PFCL would have helped, because putting the PFCL, you could see the other membranes which were first dissect those membrane, and then you can pull out the larger bits. I think that could have prevented.
Thank you, Dr. Rupak. Thank you. Please take your chair. So next, I'd like to invite Dr. Manav Jyoti Burman from Shankar Deva Netralaya, Guwahati, for his talk on how to avoid intraoperative hemorrhage.
Good morning all, and thank you Dr. Debdulal and all my co-instructors. So I'm going to speak on how to avoid intraoperative hemorrhage in vitrectomy surgery. So despite all major advances in vitrectomy surgery, still intraoperative hemorrhage is a challenge in many of the complicated cases. And this is around 1/3 of cases have significant vitreous hemorrhage, and it can be necessary repeating the procedure in up to 13% of cases. This is a rough record of the vitreous hemorrhages. So bleeding may occur from different sources: blood vessels in the sclerotomy sites, any neovascularization, or any injury to even a normal healthy vessel can also lead to hemorrhage during surgery. And extensive hemorrhage may prevent successful completion of the surgery. So grades of hemorrhages: grade 1, grade 2, and grade 3. These are again rough grading of the intraoperative hemorrhages. So grade 1 is that stops spontaneously or with a minimum elevation of the IOP. Then grade 2 is that sheets of clots away from the source of bleeding, and diathermy is required. And grade 3 is the thick clot that covers the at least half of the posterior pole and interfere with approach to the posterior plane. So mainstay to avoid intraoperative hemorrhages, one of the most important is the proper systemic control, and then preoperative anti-VEGF also has a significant role. Then peritoneal photocoagulation when it is applicable, and meticulous surgical planning is one of the most important steps. So coming to the systemic conditions that increase the risk of bleeding, this is the Hayes-Bled score. So this is many of our new surgeons may be interested what is Hayes-Bled score. It was originally designed for atrial fibrillation patients, but this later it is shown that it is applicable in almost all of the surgeries. H for hypertension, A for abnormal renal or liver function, then S for history of stroke, D for bleeding disorder, L for labor INR, that is the INR, that is the patient performing time divided by control performing time, and then E for elderly patient above 65 years of age, and D for drug or alcohol intake. So Hayes-Bled score more than 3 is considered and high risk of bleeding, intraoperative bleeding. So peritoneal photocoagulation, definitely it has a established role in preventing intraoperative bleeding, particularly in diabetic retinopathy. This diabetic retinopathy study shows that reduced risk of long-term severe visual loss, that risk of severe visual loss without treatment for eyes with moderate or severe NV increased from 6.9% to 29.7% in presence of vitreous hemorrhage, and risk of severe visual loss without treatment in case of NVD increases from 10.5% to 25.6%. And the end point of laser photocoagulation should be the complete resolution of NVD and NVE. So these are again, there are many studies that supports the role of PRP in preventing intraoperative bleeding. Then coming to the role of anti-VEGF, use of anti-VEGF agents before PRP results in superior functional and structural outcomes at 3 months to 4 months. Use of anti-VEGF agents before PPV results in decreased duration of surgery, fewer breaks, and less intraoperative bleeding. And use of anti-VEGF agents as adjuncts to PRP and PPV in complicated PDR helps in minimizing the iatrogenic damage. So multiple studies, meta-analysis, and Cochrane studies have established the role of anti-VEGF in case of in preventing intraoperative bleeding. So this is a case of ROP stage 4. You can see the radiating blood vessels coming out of the peripheral retina with a tractional retinal detachment. Fortunately, the patient has a attached posterior pole, and this already laser was tried in another center, but they could not prevent it. So patient has come to me, and we have planned surgery, but before going for surgery, I injected anti-VEGF 5 days prior surgery. So after injecting for anti-VEGF, after I have taken the case for surgery after 5 days, and you can see the bloodless surgery. I think nicely manipulate the membranes behind the lens, and there is not a single drop of bleeding from the blood vessels. So within 5 days, there is a complete reduction of the peripheral blood vessels. So this is one of the cases that shows the role of anti-VEGF in preventing intraoperative bleeding. So you can see the manipulation of the membrane is easy, and the field is also quite clear. So in diabetic retinopathy also we should anti-VEGF, you can use it liberally anti-VEGF in preventing intraoperative bleeding. So this is the end of the surgery. So surgical technique, meticulous surgical technique is essential. Careful dissection of membranes is one of the most important steps. Optic nerve proliferation should not be trimmed too short. So many times there may be bleeding from the optic nerve head, and that needs cauterization. So if we trim the
proliferation very close to the optic nerve head, so bleeding, it is difficult to prevent, stop the bleeding, and any cauterization of what optic nerve head make damage the optic nerve head. So we should leave a small stump or the optic nerve head. Anti-intraoperative bleeding must be promptly controlled. Initial management includes elevating the infusion fluid container to increase the IOP, and if necessary, IOP should be raised further by increasing infusion pressure. So how much of IOP to rise? IOP more than 40 millimeter of mercury can be sufficient to reduce mean ophthalmic perfusion pressure below critical levels, can switch to a pressure IOP of 60 millimeter mercury on encountering a bleeder, and it should be brought to normal levels as early as possible, that is within 60 to 90 seconds, and gentle pressure can also be applied over the bleeding bleeder, and we can use a hem stopper also. So any blood on the retina should be removed immediately. Clotted blood should be cautiously stripped from the retina, if necessary by using the cutter or by another instrument, and reducing the IOP at the end of the vitrectomy is one important step to see whether any bleeder is there, potential bleeder is there. So diathermy is one of the most important instrument that helps in preventing intra bleeding, and high frequency proportionate coaxial bipolar is the source of diathermy, and already discussed that very heavy biothermy can damage the retina from atrophic holes, so it should be avoided. So making diathermy a multidimensional tool, so often during the surgery, while we do bleeding occurs, taking out the diathermy and sucking out the blood, and again using the diathermy is difficult. So what we do is, in my practice, I use a very high energy diathermy up to 100%. So I just hover the diathermy probe over the bleeding site and put the foot pedal completely, and some waves will come out, frequency waves will come out, and it will just form some sort of vibration and bubble formation around the bleeders, and the blood will be dispersed, and then I will release the foot pedal to around 30%, and I will apply the diathermy to the bleeder. So it is one of the, I find it is quite useful in regular vitrectomy surgery. So this is, you can see how diathermy can be applied. So all the diathermy sites should be properly braced at the end of the surgery. So sometimes endophotocoagulation can also be used in small bleeders, that helps in the coagulation of the blood. So fluid gas exchange and vitrectomy under fluid air exchange is also one technique in case of heavy bleeders. And so rarely in eyes with excessive bleeding, thrombin may be mixed with infusion fluid to accelerate the coagulation process and reduce bleeding. And other methods include viscoelastic, silicone oil gas, and perfluorocarbon liquids to prevent bleeding. So in conclusion, modern vitrectomy surgery enables more control of intraoperative bleeding, and given the seriousness and potentially blinding consequences of severe intraocular bleeding, it is reasonable to prepare the patients in advance, and that includes systemic control and careful surgical approach. Thank you so much.
Thank you, Dr. Manav. One question to you is, what would be your advice regarding stopping disc hemorrhage?
That is what this hemorrhage that I prefer, that I'll never cut it NVD very short to the disc, and so that I can cauterize the disc. And if it bleeds, then of course FG or silicone oil is the option.
Yeah. So regarding, could you please once more explain what you meant by 100% diathermy and the bubble thing that you mentioned?
That is what that whatever the new diathermy machines, particularly whatever comes with the Constellation machine, so we can give the power up to 100%. So that is around 60 something. So whenever we press the foot pedal, so it will give the 100%. But with 100%, if we apply to the retina, it will instantly form a break. So I don't apply directly over the retina. I just keep it slightly above the bleeder.
Yes. So this is something very important that he mentioned, that with 100% cautery, if you touch the retina, then it's going to blast off the retina. So it has to be a little away from the retina, so there will be bubble formation, which will be good enough to take care of the bleeders. So this is, I think, a very useful step that we often follow. So thank you, Dr. Manav. Next, Dr. Boral will speak. Yeah, please go ahead. So he will be actually telling us about subretinal pathology, and subretinal pathology is not only to be handled by you know, after a lot of gaining lot of experience, but you have to start someday, and so why not start now? So Dr. Boral, please.
So, very good morning. So, thank you, Dr. Debdulal, for inviting us in your IC. Slide, please. Yes. So, managing subretinal pathology safely, basically when some pathological, like any mass or any media haziness, anything is there in front of the retina, it is very easy to tackle. But when it is just subretinal, you have to you have to do as little as possible to avoid undue further complications. Like these are the pathologies that you often need some kind of surgical intervention, like subretinal hemorrhage, subretinal scar, subretinal PFCL, subretinal bands in chronic complicated retinal detachments, and subretinal cysticercosis. So subretinal hemorrhage, it is often we have to manage so promptly and so urgently for the prognostic point of view. Subretinal scar, often we are just leaving it as such, not removing the scar material from the macular area. And subretinal PFCL, if it is like within the macular area, it is threatening the fovea, you have to remove it. Subretinal bands, it depends. Dr. Rupakas already showcased his videos that subretinal bands has to be removed in chronic complicated RDCP if it is causing undue traction or tainting of the retina. And subretinal cysticercosis, obviously, if it is whether it is live or dead, you have to remove it. So now I'm coming to the submacular hematomas cases. Like this is the simplest technique. It is after doing vitrectomy, if you are intervening and there is large submacular significant hemorrhage, so you have to remove, you have to remove it. So, but removal of subretinal hemorrhage from this macular area sometimes it's very difficult. So our minimalistic approach is after doing vitrectomy, you have to give cocktail of subretinal TPA, anti-VEGF and air. So after giving subretinal TPA, the spot lysis occurs and the blood color changes like this. You can see the black colored blood, little bit dark colored blood. Now it is quite light colored blood. So after giving subretinal TPA injection, blood color will change after 10 to 15 minutes like this. And there will be, due to the gravity, the RBC will settle down. And if you are giving subretinal air in this sense, the air will displace this RBC lysed blood inferiorly due to its gravity situation. So this is the logic of giving the subretinal cocktail of and anti-VEGF obviously directly act on the CNVM where the target tissue is. So subretinal, this is both combination of sub-RP and sub-neurosensory retinal hemorrhage. So preoperatively vision was accounting close to face. I started doing vitrectomy, and after triamcinolone PVD induction, with the help of 38 gauge and non-metallic cannula, I'm giving subretinal TPA first, and as well as some amount of RTPA, sub-RP also. Basically, there won't be much difference if you are giving sub-RP also and sub-retinal TPA. And just see the change of color. Now I'm giving subretinal anti-VEGF along with air. The air will, when the patient will maintain the propped up position, the air will move up and the light spread will go down. At the end of the surgery, you can just maintain the patient position, first initially propped up, followed by prone position. And postoperatively, you will see this kind of beautiful picture with good improvement in vision. So it is another situation where the bleeding was more extensive, and I am giving the subretinal TPA with the help of metallic 41 gauge needle, and doing some kind of retinotomy here in the paramacular retinotomy into the supratemporal quadrant. You can see the light blood is coming out. So you have to remove blood as much as possible, if possible 1 or 2 retinotomy, either on the diagonally opposite quadrant or the opposite retina is relatively healthier. You can make the another area extramacular retinotomy, but and you can see after doing fluid exchange, just inject subretinal, not subretinal, intravitreal anti-VEGF injection. At the surgery, you can inject oil also. So you just slowly vision will improve after 3 months. After removal of silicone oil, patient gain good vision, and there was absolutely lack of retinal hematomas. So this is another tricky situation, that is subretinal PFCL. So how to manage this subretinal PFCL? So if you see the subretinal PFCL, I will differentiate in OCT. That actually this angle is called angle kappa. So if the angle is obtuse, that is more than 90 degree, so this is actually, I'm just sorry. When this bubble is making, when this bubble is making some kind of angle with this line, you can see it here, you can see it here. I don't have the pointer. You can see the angle is more than 90 degree in subretinal PFCL case, but it should be in acute angle when the subretinal serous fluid is present. So this is how we have to differentiate whether it is subretinal PFCL or subretinal fluid. This is called angle kappa. The slide is not moving. Slide is not moving. Okay, now.
Micro VFC, a simple indigenous new tool to access subretinal space in a controlled way. VFC, that is viscous. Micro VFC, a simple indigenous new tool to access subretinal space in a controlled way. VFC, that is viscous fluid control, is commonly used in vitreoretinal surgery to inject silicone oil within vitreous cavity or to extract it in a faster way. We developed a simple indigenous modified VFC to gain access to subretinal space in a controlled way. We have removed the plunger, cut the rubber cap of the plunger of a 1 ml syringe. This cut rubber cap was fitted inside an empty 1 ml tuberculin syringe. Its end was fitted with the tubings of VFC of vitrectomy machine. Now VFC mode was activated. Attaching an either 38 gauge or 41 gauge subretinal needle to the syringe to extract the retained submacular PFCL bubbles or to deliver precise dose of subretinal drugs like RTPA for subretinal hematoma in a controlled way. Here the cut rubber tip of the plunger can move smoothly within the 1 ml syringe during injection or extraction mode of the VFC attached with the vitrectomy machine. We named it Micro VFC. Firstly, the practical application for extracting the subretinal retained PFCL bubbles. Here it's a case of status post-vitreoretinal surgery with a retained subfoveal PFCL bubble with best corrected visual acuity 2200. I used our Micro VFC using metallic tip 41 gauge cannula in this case. After extracting the silicone oil, I went ahead with this Micro VFC. I directly pierced the fovea with the metallic tip and made the extraction mode on with around 300 to 400 psi to aspirate out the PFCL droplet. Fluid air exchange was completed. Post-op best corrected visual acuity was 20/80 with complete absence of subfoveal PFCL bubble but with a small tag at the point of entry on OCT. In our second case, post-surgery for giant retinal tear, there was a large bubble of submacular PFCL threatening fovea with best corrected visual acuity 20/60. After removing silicone oil, I used this Micro VFC with 41 gauge metallic tip cannula to remove the submacular PFCL bubble. Using viscous fluid extraction mode with 400 psi extraction pressure, PFCL bubble was extracted completely. Post-operatively best corrected visual acuity improved to 20/40 with complete absence of submacular PFCL bubble. I also used this Micro VFC for delivering drugs in subretinal space. Like in this case of post-PCV massive submacular hemorrhage with best corrected visual acuity, hand movement close to face, PR accurate, I did vitrectomy with complete removal of posterior hyaloid face. Here I used our VFC with 38 gauge non-metallic cannula for injecting recombinant tissue plasminogen activators 0.05 cc, that is 50 microgram, directly into the subretinal space through a mostly elevated area just outside the macula for clot lysis. The subretinal injection of RTPA was completed in a very controlled way. Again, I have used combination of anti-VEGF ranibizumab injection 0.05 ml and filtered air 0.03 cc and injected slowly in subretinal space outside the macula. Then I completed fluid air exchange and used sulfur hexafluoride gas tamponade. After 3 weeks, best corrected visual acuity improved to 20/120, significant reduction of submacular hemorrhage with
Drug delivery. So this is another cases Dr. Rupak has already showcased is removal of the subretinal PVR changes and subretinal bands. Like in this also a case of very old RD, complicated RD, multiple subretinal bands were there. So in this situation, that bands is directly going through the macula. So I have made one just just at the side of the subretinal band. You have to make the opening here and remove the subretinal band. And here I am removing it bimanually, and it was quite very thick, and it was adhered to the overlying retina. So you have to be little bit careful to remove the at least macular subretinal band, otherwise it will cause stenting at the macular area. So this is one technique. Another is if the already the break is inferiorly, and you can see the very large taut retina inferiorly, you have to make large relaxing retinectomy, and directly through this retinectomy area you can go subretinally and judge your subretinal sheet of membrane. Here sometimes it is present as a band, or sometimes it is as a whole sheet of membrane. So multiple layers subretinal the sheet of membrane or bands, it can be removed with a single go. And many times this kind of in this case of GRT also, you can see the along with the inferior arcade, the band is going and it's causing traction, a lot of traction. So you have to remove it under chandler's light. Often you have to remove it bimanually. So these are the things you have to be very careful. Like another situation is subretinal cystosarcosis, where actually cystosarcosis, it is the actually ingestion of eggs of tinea soilium. It can cause and reach the subretinal space through the posterior ciliary artery and the choroid. It can be live or dead, and a lot of other investigations, eosinophilia, ELISA.
Shubhenduda will have to.
Yes, I'm just ending it. CT brain and MRI is required. And the safest way to remove this subretinal cyst is just beside the cyst, you have to make a small retinotomy. Slowly you can remove from the subretinal space, and finally end the case with the gas tamponade. Thank you.
Thank you so much for your wonderful videos and your tips. So next I'll be showing some cases. So thank you for being here last day, in the morning hours. So basically, nothing is, sure in life, and you have to actually, be careful every time. A good judgment is to make the best decision based on known information. But for, good judgment, you have to have some amount of experience, and experience comes with doing things and not by sitting in the couch. So, some basic things. Don't forget to, check out, even after you've done your 1,000 vitrectomy, don't forget to, check out where you are injecting your stalker cannula. So, let's look at this, why this is important. So you have to visualize your cannula inside. As you can see here, you can visualize the cannula. So this is something very important. Do it before you begin your surgery. Otherwise, what happens is, after a time you become complacent and see just, keep watching this area. So you have, subretinal intuition here going in, and, you have a suprachoroidal intuition. So you need to, stop your intuition, go to a different port and check whether it is inside the vitreous cavity or not. And then what you do is, ideally you can take a 6 mm cannula. So I'm taking a 23 gauge 6 mm cannula here and making a separate port. And again, don't be too sure that you have a 6 mm cannula is going to go inside, but you have to check. So this time you can, sort of be sure that you are inside, and then you can start your surgery again. So this is something that Dr. Aniruddha has also shown, and see where my assistant is injecting, and he injected in a jet, and see what happened with the BBG injection. It has gone subretinal. So once you clear up the BBG, you see it is subretinal. So ask your like assistant to be gentle, and in these kind of situations, sometimes these can create trouble. Maybe you might do laser, you might not do laser. And of course you need to do gas to sort of tamponade for these macular holes. So this is how it looks at the end. So let's look at this case. So this is a routine macular hole case, but just see here at the end of the surgery we found that this area was lifted up. So we did laser barrage here, and you have to drain the fluid out. And once you have drained and you settle the RD, then you need to do a little bit more laser on this area so that this doesn't progress to a detachment in the post-operative period. So this is something, it's very important to check your periphery and see whether, because of the vitrectomy and the shaving of the ora, etc., you've not created any iatrogenic retinal detachment. So next is this subretinal hemorrhage. This strange, this is basically a retinoschisis related RD. So you have this owl-shaped owl eye looking, like breaks looking like owl eyes. So once I started doing, laser here, I realized if you look at this part, the laser was not, taking up. So I realized there's a traction here, and so I started doing a, limited retinotomy. So as you can see, the cautery is holding up the retina, and therein, you start, you have a subretinal bleed here. So the subretinal bleed can be managed. It can be, you can take out the subretinal bleed with a flute needle, and once you take it out, you need to laser up the area, and you can, be sure that this is not going to create trouble subsequently. Now let's look at fish egg formation. So when you inject PFCL, you can have fish eggs. Just soak the fish eggs; they will go away. And ask your like assistant to be gentle. Again, you see lots of fish eggs, and you can just inject within the PFCL bubble. You just make like movements with your and you can have the fish eggs going away. So another important thing is when you are in fluid air exchange, don't restart the infusion at a very high flow rate. Otherwise, you can have jet stream breaks here in this part. So what you basically do is you use the infusion to maybe around 15 or so, and then you gradually fill up the vitreous cavity so that you can avoid this is very important. Now, nowadays we don't have too many FAK cardies, but just to show how to manage, a silicon-filled FAK cardi, the AC part of it. So once you have, filled up with silicone oil, so you can, what I'm doing here is injecting some pilocarpine so that the, iris, the pupil becomes constricted. And after that, it's important to inferior PI. It's very important. Otherwise, you'll have, tremendous rise of pressure post-operatively. The whole purpose of the surgery will be lost. So, that you can see I'm doing an inferior PI. And once you've done this inferior PI, what you can do is you can go in with a 3 mm, syringe. You can, inject some fluid, and you can cross-check your how the pressure is, and then it's a good idea to close this. I usually close my silicone oil filled eyes. So thank you, and that was the last video. So we are open to a little bit of discussion. I think we have maybe just a minute's time.
Yeah, you have already shown that very important point, the inferior PI. That often you have to do some kind of gentle cautery, otherwise postoperatively you may face.
Yes, some of them do bleed, and so in such situations, the postoperative cautery is in order.
Doing cautery into the PI, it's like double-edged sword. If you are doing cautery, it will be closed, and if you are not doing it, it can end up with high fever.
Yes, yes, and actually, with
Sometimes it close. It's
yes,
not always close.
and in fact, if you do a cautery, what sometimes we've seen is it enlarges a little bit because
Yes.
there is constriction, all around, and it enlarges a little bit and keeps the PI open in the post-operative period also. There'll be, it'll not close up. Yes, Dr. Rupak has a point to make.
There we get RDs, they present very early. We tend to operate them within 1 to 2 weeks. We emphasize more on using gas rather than oil. And in case of PVR cases, I think everything is covered today. Only one thing is buckle, which is 276 buckle, which I think is very helpful. And do retinectomy, which is last option, but in a stage manner. First you put oil, leave it, see the patient again in 4 to 6 weeks, and then you do retinectomy. The idea behind this is that it's mainly because of the RP which is causing it. So once the jelly is out, the RP is out, the inflammation is out, and then you will not get a recurrent PVR. Otherwise you cannot study detachment or you will get recurrent PVR. And to trainees, I'll only say, always see the patient before surgery and make a plan, stick to that plan. You don't need to be a very efficient surgeon, but the decision making is very important in your surgeries, and you will avoid all the complications because of that. Thank you.
Yes, I think, very important points, and it's very important not to, be scared once you have some iatrogenic complications, because you will have complications as you go along and operate, cases. So, but, to move on after the complication is very important. So, any further comments, questions? So, I think we'll hand over the dais for the next, presenters. And can we have a photograph? Yeah, yeah. Would like to invite Dr. Priyam, Dr. Ashmita, Dr. Rupak. Please come. And thank you, audience, for your participation.